Great. Good morning. I'm Smita Bhatia, and it is my absolute pleasure to introduce Dr. McQuaid. Dr. McQuaid comes to us from Brown University, where she's a research professor of psychiatry and human behavior. Her research interests include psychosocial and cultural aspects of pediatric asthma and food allergies, including adherence to disease regimens and individual and family characteristics that influence pediatric outcomes. Dr. McQuaid is board certified in clinical child and adolescent psychology and has been named a fellow of Division 54 in pediatric psychology of the American Psychological Association. I have to speak a word before I let Dr. McQuaid take the stage. She is a friend of mine. How did we get to know Dr. McQuaid? We called it yesterday researchmatch.com. So it started off with Wendy and I wanting to develop an intervention for adherence to oral chemotherapy in children with cancer. And we had put in the grant unsuccessfully a couple of times. And one of the reviewers was, or actually more than one reviewer, was very insistent that neither of us was a card-carrying psychologist or behavioral scientist. And so I literally went online to look for somebody who was the best of the best. And that's Dr. McQuaid. So here we are, and we got the R1. Thank you.
Thank you. That was so nice. Thank you. So you know how people put together slides or posters, and then like at the last minute you notice there's a typo and you think, oh. So apparently I gave this talk yesterday on the 25th. But I got taken to a really nice dinner last night, so I'm thinking it went okay. Just the mandatory disclosures and learning objective slides. So given the focus of the day, my overview of medication adherence is going to be super brief because it's been covered in such a really nice conceptual and methodologic way in the first two talks. I'm going to talk about evidence for different patterns of medication use across different racial and ethnic groups, and also barriers to consistent adherence across different levels, including the healthcare system, family, cultural, and individual level. And I do want to mention that, I work with kids primarily, so I do think a lot about families as well as individuals and parents in terms of the decisions that they make in caring for their children. Then I'm going to use an example from one of our studies, the Rhode Island-Puerto Rico Asthma Center, where we looked at healthcare disparities in pediatric asthma among Latino and non-Latino white families of children with asthma. And then I'll end by talking about sort of what strategies might we think about and what could work to address this issue. So over the past several decades, there's really been more and more of an emphasis on self-management and family management of disease. So people leave healthcare providers' offices with a lot of directions to do a lot of different things. And adherence to disease regimens, particularly chronic ones, can include a lot of different tasks. And that involves taking medications as directed, but also it can involve identifying and monitoring symptoms and communicating with healthcare providers about those symptoms and changes, and also making lifestyle modifications too. And as Dr. Curtis mentioned, we're overloaded with recommendations really at this point from lots of different channels, more than ever before. It's really not anymore that the healthcare providers are the ones who are giving us the majority of the advice. We have our families. We have all of the ads that come across TV with all of the recommendations and cautions. And of course, there's also the internet. So there's just a lot of information that is coming into families and patients about what they should do or shouldn't do to manage their health that happens outside of the healthcare provider's office. So when we talk about medication adherence specifically, often we're talking about how much medicine is taken as prescribed, but there are a lot of different elements to this as well as was discussed previously. Did you take that prescription from the physician? Did you go fill it? Did you take the medications as directed? And I work a lot with adolescents, and so this idea also about making decisions to discontinue and adjust, whether or not you loop in your healthcare provider when you do that, is also another important component. So there has been a lot of research in adherence, and over a decade ago there was a meta-analysis that looked at sort of 50 years prior of adherence research and found that adherence was not that great, and it tends to be higher across, when you look across studies at some of the more severe illnesses, HIV, GI, arthritis, and cancer, tends to be lower in pulmonary, diabetes, and sleep. And there are some pretty consistent age effects where it's higher for adults relative to kids. And when you look at adherence in children, you definitely see age effects over developmental effects that you would expect. So when parents are on top of things, it looks a lot better. And then when you start to get into adolescence, and in particular high school, there are some significant declines in adherence. And this is consistent across different kinds of illnesses. Healthcare disparities is also a big topic and an important one as it relates to medication use. So when we talk about disparities, we are talking about population-specific differences, and they're often looked at in terms of bigger data sets, to disease, health outcomes, or access to care. And it's hard in a lot of ways to merge some of the larger data set findings that we have with the clinical findings that we have as well. Because really trying to understand health disparities in relation to chronic diseases and even acute diseases involves sort of taking into account the socioeconomic barriers, in addition to race, ethnicity, social status, segregation, immigration status, et cetera. So there are many, many confounds here that we need to be thinking about as well. And often the data don't address them in a way that that makes it clean, because it's not. Health disparities are really pervasive across illnesses. They're persistent and they cost a lot, and they're found in so many conditions. So maternal health, prenatal, nutrition, flu vaccine, on and on and on, and even more. So this is a very persistent and pervasive issue. In terms of medication use, there has been, there've been a number of studies that look at adherence to medications across different socioeconomic groups and different racial and ethnic groups. And just to highlight some of the general findings, it is the case that Blacks and Latinos are more likely to report lower adherence to antiretroviral medications. And antihypertensive medications is lower among, adherence is lower among Blacks relative to non-Latino whites. Diabetes as well. Adherence to controller medications for asthma as well, lower for Blacks and Latinos. And then some important work from Dr. Bhatia's group as well, adherence to oral 6-MP for pediatric cancer, lower for Latinos, Asian Americans, and Blacks relative to non-Latino whites, and this is associated with higher relapse risk. So the associated potential outcomes are also concerning. So why? I have a red alert here because we're in the high-risk zone here for making stereotypes, making generalizations, making missteps. So I just want to kind of take a step back and try to be thoughtful about how we try to explain and understand these trends that I just mentioned, or these findings that I just mentioned. And really, it's the case that there is not a simple answer to this, and I think that people sometimes are looking for that. Like, maybe it's just poverty, or maybe it's just use of alternative medications in this condition, and there is no simple answer. There are patient, provider, cultural, historical, and healthcare system factors that are all operative in terms of understanding this phenomenon. So I'm going to talk some about these multiple levels in the next set of slides. I want to talk for just a moment about discrimination in healthcare, and again, this is something that could be the focus of a huge conference, of a life's work, and it's really hard to, I struggled with what to put on this slide. Like, you don't want to pay lip service to this. You're not going to put some clip art. It's really an important thing to be thoughtful about. And so ultimately, the two things that I want to say are that it's very true that racial and ethnic minorities experience discrimination on multiple levels in healthcare settings. And this can be due to race or ethnicity, social class status, immigration status, language preference, and other types of minorities as well experience discrimination. There's consistent evidence that this is true. And also, among many African Americans, there's also distrust of the healthcare system, medical providers, and medical research, and there are deep historical roots to this. And if this is something that you know just a little bit about, it's really worth diving into this, because understanding, I think, some about the history there really helps to understand the context of some of the disparities that I'm going to discuss as well. So in 2002, the Institute of Medicine did a very large report that they released about healthcare disparities. And essentially, the take-home message is that there's a lot of variation in rates of medical procedures, even the most routine medical procedures, by race, and that racial and ethnic minorities experience consistently a lower quality of healthcare service. And one of the somewhat controversial findings that came out of this, or quotes and thoughts that came out of this, is that although that there are many different sources that contribute to these disparities, there definitely is evidence that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to differences in care. So the call is coming from inside the house. We've found the enemy, and it is us. We need to take a look at ourselves, in terms of, and as healthcare providers, in terms of what we may do to perpetuate this. So why could this be? Now, we know in general, healthcare providers have good intentions, and that's why they've chosen the profession they've chosen, or we have. There is some evidence that communication patterns differ between healthcare providers when they're interacting with patients of color. And some of that evidence comes from primary care. And there's a whole methodology around doing this that's really interesting. And it involves some audio taping and sometimes videotaping, and having transcripts of office visits, and really quantifying the communication patterns that happen. And there is some evidence that primary care visits for Blacks contain more verbal dominance, statements of direction, and less patient-centered communication. And, these are just some examples. In one large pediatric survey, which was nationally representative, minority parents were more often asked about violence, smoking, drinking, drug use. And there is consistent evidence that providers less often refer minorities to specialty care. Again, these are a few examples, but there is a lot of evidence. Again, the question sort of is, so why? Why is that? Some of the thoughts around this, I think, are really useful in terms of how we think about how we need to rely on stereotypes in healthcare communication, healthcare situations. So, although the healthcare providers, we do have good intentions, that there is a thought that there can be implicit biases, and that these are more likely to be operative when you have limited time, limited familiarity, and you need to make decisions quickly under clinical circumstances. So these are the circumstances under which we are trying to make decisions, and our cognitive sets make us rely more on stereotypes. And so that's one of the sort of theories behind why there may be different patterns of communication that are operative. Also important to talk for a minute about language barriers, because I think this is one area, there is some research and it has some really interesting findings. There are some findings, not surprisingly, that as background, the limited English proficiency, people who are of immigrant status come into healthcare situations without English as their primary language, often have other sources of disadvantage as well in terms of their level of acculturation, socioeconomic status, their insurance status too. In addition, when families with limited English proficiency come in, there can be practices under resource-poor situations where family members are used as ad hoc interpreters, and this can complicate health communication. There is evidence, though, that even when trained health interpreters are used, that healthcare providers spend less time listening and make fewer statements of support to families of limited English proficiency. And you can sort of see how this could happen. If anyone has worked with interpreters before, you know, of course, it takes time because there is the time to translate the healthcare communication. And there's also, you know, a focus on making sure that you're clear. But as a result, those interactions are characterized by less support. In pediatrics, too, this becomes complicated if you have a situation where the parents don't speak English, and yet the children do speak English. So one of my postdoctoral fellows did a really interesting study in pediatric asthma looking at that circumstance when the parents spoke primarily Spanish and the teenagers did not, and the teenagers were sort of used sometimes as interpreters. And it included some qualitative and quantitative data collection. But I have some quotes here. And it was really amazing to us, maybe not shocking, but sobering, that how much youth report purposefully editing medical information. So this quote, when the doctor says something, I just say what I think is important. Like, he'll tell me a whole bunch of stuff and I'll censor it. I have to translate for my mom, but I get lazy. Like, bring a translator. I don't want to talk. I won't lie sometimes. When they tell my mother things and it makes me look bad, I seem to forget what they said. So, but they do appreciate attempts at good communication. And this is one of my favorites, too. She usually realizes it because doctors don't use typical words that humans may use. So she realizes it and tries to explain it as best as she can to make sure we understand. But you get a sense of how incredibly complicated, right? How complicated this is, and how health communication really can be skewed by a number of different factors when language is an issue. I think it's important, too, to talk about complementary and alternative medications for a moment as well. And, you know, this comprises a number of different things. So you have things like massage, chiropractic, yoga, spirituality, homeopathy, energy therapies, and then biologically based approaches as well. So there's a whole range of things that people can do that are outside of what might be the traditional medical recommendations as well. And there's consistent evidence that a lot of people do this, more than 30% of adults, about 12% of children. And so that's either in combination, complementary to what the traditional approach that's being proposed is, or as an alternative. And it's important, too, to think about how this interfaces with people from different cultures, because the person who is, you know, in the yoga class or doing hot yoga is not necessarily the same person who's going to the bodega, could be, but maybe not, to get the supplement from the Dominican Republic. So there are different things that different people use as well. So it's not sort of a monolithic thing that you can really ascribe to one group or another. It varies a lot across racial and ethnic groups. So, you know, we were interested in our work, and there is some interest in looking at whether or not using complementary and alternative approaches means that you're using less of the traditional approaches, sort of an intuitive hypothesis. So we, in a study I'm going to describe a little bit more later, we looked at what parents reported they were using for their children with asthma, and we have a large sample of families from Rhode Island and also who are non-Latino, white, and Latino, and families from the island of Puerto Rico. And we found that use of complementary and alternative medications was higher in Puerto Rico, and it was higher among the ones we were measuring among the Latinos in Rhode Island as well. And it was related to barriers to obtaining medicine in Puerto Rico. So in Puerto Rico, people were using more of these approaches when they couldn't get the medicine. That was more frequently reported there. And it wasn't related to medication adherence, so how much they were taking the prescribed medication among our Latino children, but it was positively related to medication adherence among our non-Latino whites. And so in some ways, it's not an inverse relationship and it's not a straightforward thing. We, sort of concluded in this group that there are people who are kind of like throwing everything at the problem to try to address it, as opposed to using one thing instead of another. In HIV also, it's not completely clear if those are inversely related. There's one study that found that CAM use was very common, but not associated with lower adherence to antiretroviral therapy. And then there was another study that found the opposite, that it was associated with lower self-report. So it's not really clear. But one thing that has been concluded about work in this area is that it's important to ask about it, because people do not typically report that that's what they're doing. That's definitely one thing that they do not voluntarily disclose. So if you don't ask, you're not going to find out. At an individual level, there has been some pretty consistent work in depression across diseases that depression and depressive symptoms is related to lower adherence. And this holds across a lot of conditions and also, for adolescents as well as adults. And also that, and now this is perceived discrimination. So this is the person's report of discrimination, not which is likely related to actual discrimination, but this is a self-report measure. But it also has been found to be related to lower adherence. So people who report that they feel like they're having these experiences in the healthcare system that are discriminatory also are less likely to be taking the medications that are recommended directly to them by their healthcare provider. And there's also evidence that these things can be synergistic, that they can operate together as well. So, and looking at antihypertensive medication adherence, perceived discrimination is associated with lower adherence to antihypertensives among African Americans in some studies. And in one study, this relationship was accounted for by stress and depression. So these things can all be sort of linked together and account for some lower medication use. Medication beliefs is another area where there has been a lot of research, and there is some consistent evidence that there are more concerns about taking daily medications for chronic conditions among different cultural groups. And that's consistent across asthma, COPD, like a number of different illnesses. This is a very consistent finding. And it's important to keep in mind that I think this is another thing we kind of grab on, like, medication beliefs. If we can just change the beliefs, that'll be sort of an easy intervention. But they can be influenced by history, as I mentioned, culture, family experience, and individual preference. So it's not just beyond, it goes beyond what you say about what the medication is and the pros and cons and the risks in the actual medical encounter. It also is influenced by a whole host of other contextual factors that are important to keep in mind as well. So one of the questions that comes up, and the previous speaker mentioned this as well, do the concerns about medications outweigh the potential benefits? And there has been some research in this area as well. Also in HIV, it's important to mention that there are a lot of concerns about antiretroviral treatment and also concerns about HIV in general. And there's some data that from a large survey that showed that African Americans tend to endorse, are more frequently endorsed that a belief that HIV is a man-made virus, and that significant concerns about medications for HIV as well. So these are real concerns, for many people in the community. And there are data to show that if you have those concerns, not surprisingly, you're going to be less likely to follow through on the prescribed medications for HIV and AIDS. So I'm going to talk some about pediatric asthma and show you some of our data and how we looked at this specifically. and looking at the healthcare system factors, family and individual factors, using some of the variables that I've mentioned. Just one slide of background on asthma so that if you're less familiar, so you have this context. Basically, adults and children who have persistent symptoms are prescribed controller medications. These are typically inhaled corticosteroids, but there are other alternatives available as well. There are lots of good reasons to take these. In terms of disease control, they do have minimal long-term side effects, some, but minimal. But they don't have any immediate effects on symptoms. So this is one of those situations, like antihypertensive medications and other medications where you have to take them for a long time. And in contrast to a quick relief medication for asthma, which has an immediate effect, and the bronchodilator. So the research in this area shows that when people do fill the prescriptions, they take about half of their prescribed doses of controller medications, and that lower income families take less medications, and minority patients have lower adherence rates relative to non-Latino whites and middle and upper income patients. So we have we finished a large study in collaboration with colleagues at the University of Puerto Rico, the Rhode Island Puerto Rico Asthma Center. We did a lot of clinical and survey evaluations on over 800 kids with asthma. The three groups were, as I mentioned earlier, children on the island of Puerto Rico, primarily San Juan, non-Latino white Rhode Island children, and Latino Rhode Island children. And in Rhode Island, our Latinos are primarily, at the time of this study, of Puerto Rican and Dominican descent. So now I know what some of you are wondering, like, okay, what now? This is the Brown Gates, we're in the Northeast and Rhode Island, and does it even make sense to be doing this study there? Rhode Island is a nice example of a place where we've had, an explosion of our Latino population in the core cities. People come to New York often with their families, and they move up the coast and find that a smaller state or a smaller city is more family friendly. So Providence, as of the 2010 census, was almost 40% Latino families. Pawtucket, a nearby city, also 20%, and Central Falls is over 60% Latino. So we have we have a sort of a rich mix of Latino families in Rhode Island. And asthma is more prevalent among Latinos and is more severe as well. And so this is just a map that shows you that in the core cities, which are Providence is sort of up here at the top of the bay, there are many, many more asthma hospitalizations and hotspots due to asthma. So we were interested in, we had many, many questions for the study, but one of the things we were really interested in was what predicts rates of controller medication use among the Latino and non-Latino white families? So if you think about kids with asthma, all the kids with asthma up here, right? Not everybody has persistent symptoms. So some people they wheeze when they exercise. They only need the quick relief medication. They don't need to be taking controller medications. And then there's this group who should be taking controller medications by medical guidelines. That's what's indicated and recommended. And then there's a subset of those who actually report having them. And then there's those who have them. How much do they take the medications? So our two questions that I'm going to talk about briefly here are, what predicts this, sort of out of those who should, by medical recommendations, have a prescription, to actually report they have that? And then what impacts taking medication, how frequently you take it if you have the medication? So in terms of our first question, we looked at only kids who had persistent symptoms, and that was determined by a full clinical evaluation, including the whole 9 yards and et cetera. So we had over 500 kids total who fit in that category. And we looked at just whether or not the families reported they were on this medication. So we did not have access to whether or not it had been prescribed. We had access to, what did they say they were on? And then we asked about beliefs and barriers to medication use. We did use the Beliefs About Medicine questionnaire that was mentioned in the previous slide, and I'm relieved to say that we did ask them, thinking about your controller medications, please do answer these questions, with those in mind. So hopefully it was a little more specific in our case in terms of getting at parental beliefs about medication necessity and concern. So one of the things about this instrument is that you can look at sort of this pro-con analysis. So you have the how much people think it's useful versus how much are they concerned about it. And higher scores reflect sort of a better, more favorable attitude towards it. And you can see amongst our sample, the non-Latino whites have the most favorable. The Rhode Island Latino families have the next. And it's kind of close to zero for the island Puerto Rican families. So those families are the ones who are really saying, I sort of see that it's important, but I also am really worried about it. And so if this is the mean, that there's some people down here who really believe that have a level of concern that's much higher than their belief in that the medication is important. And so we found that this score was associated with the report of how much they had the medication on hand, how much they said, this is what my child takes for asthma. And also in Puerto Rico, we found that, again, the healthcare context, the barriers that the families reported to getting and accessing the medications was another predictor as well. So we also were interested in, what we've been discussing here in terms of actually consuming the medication. How much, if you've been prescribed, you're prescribed it, you say that you're taking it, how frequently are doses taken? So again, that's a smaller subset of our sample. So we had a little less than 300 patients who were taking controller medications. We had their medication use monitored electronically for 5 weeks, and this was quite an effort to we'd been doing this in Rhode Island for many years, but to implement this kind of electronic medication monitoring in San Juan introduced some additional challenges, but we were able to do it. We do tend to exclude the first few days of data collection. And also, one of the interesting things about our asthma devices, and I'm just going to put them up here, is that, they're different for different medications. So there is an oral controller medication for asthma, and we use the traditional sort of pill cap. There are dry powder inhalers where there's a counter on it. So these are all somewhat different methods of medication delivery and measurement, which is somewhat confounded. This one is what we use for inhalers, and one of the interesting things about this is that it measures not just whether or not you are discharging the inhaler, but this device has like a temperature-sensitive thermistor in it, so it measures whether or not it's inhaled. So we actually do look at consumption, and pretty consistently across our studies find that, what we call the parking lot phenomenon, where somebody is like in the, oh my gosh, I'm going into the study, and and so it's, and so we have definitions around how to exclude those data as well. So more than 10, you really can't take that more than 10 times a minute without inhaling and be ingesting the medication. So all of that gets excluded out of our data. So again, a similar finding that we have the lowest rates of adherence. These are across the 3 different kinds of medications that we monitored. The lowest rates for the island Puerto Ricans, the middle rates for the Rhode Island Latinos, and the highest rates among our non-Latino white sample. And but we were interested in sort of why and what predicts this. And it's really important to try to account for the fact that these children and families are in very different healthcare contexts, and they're sort of embedded in different social and contextual environments as well. So we used multi-level models to be able to account for that, so that where people are sort of nested in their own, their own context within the analysis, which helps account for the fact that the healthcare systems are really very different between the sites, and the experiences are also different. And we found that doing that, we also, controlled for child age, which, as I mentioned, is a confounder. The older kids, they just do less, and medication type as well. We found that family routines regarding medication use was associated with greater adherence, and parental beliefs about medication necessity also associated with adherence. So both sort of individual parental level variables and families' organization around routines also. And this is, again, this is within the multi-level model, so it bears across the different samples. So in some ways, that gave us some really useful directions for interventions that could be applicable across the board for these families. One of the most interesting things about this study, for me personally, is learning more about the healthcare system. I think that, we know there are variations in the healthcare system here, but really the medical care in the United States is really good on the mainland in general. When we were doing this study in Puerto Rico, they were operating under, a lot of the pediatricians were operating under a capitated system where they got a certain amount of money to manage their patients' asthma. That money included medication costs. And yet they knew that if they sent their families to the emergency department, they would get the same medications, but it comes out of a different bucket and not theirs. And so, there were some important incentives in place for physicians not to be prescribing medications and, in fact, to be sending their patients to urgent care settings. And so I think that this is kind of a cautionary tale as we're in the middle of really a sea change in our own healthcare systems, in thinking about how the models of care and the systems could potentially have unintentional effects on medication availability or medication prescription and cost for patients and families. So let's talk about what interventions could potentially help. And it's not, there is some good news. It does feel daunting. Healthcare disparities are, they're a big issue, and there are many, many, many factors. But I think there's some good directions in the literature that we have that we can apply and think about bringing to bear on some more novel interventions. I think it's important. One thing is having the data. And I mean having the data locally. So, for example, it's kind of easy if you're working within a healthcare system, if you don't have the data, to say, well, I know that the national data says this, but that happens out there. And, here in our healthcare system, we are very thoughtful, and that's probably true. But there are still a lot of barriers, even locally, to collecting data to look at the question about whether or not there are disparities happening right under our nose. And I think that that's very important, because having that information is what makes us more accountable within our own organizations of having to address. So there's some evidence that cultural competence training can be useful as well. So there was one study in pediatric asthma that came out over a decade ago that showed that amongst Medicaid managed care organizations specifically, the ones that had provided cultural competence initiative or had cultural competence initiatives also had families or pediatric asthma patients that were less likely to be underusing preventive medications. So there is some evidence that physician training and healthcare provider training around cultural competence is can have an impact as well. And there was another study that looked at HIV clinics, urban HIV clinics, and asked the providers themselves to provide ratings of how culturally competent they thought that they were. And their ratings were associated with how frequently patients were receiving antiretroviral treatment prescriptions, adherence, and outcomes. So those are encouraging, but it's really important, I think, again, it's important not to oversimplify, because this is one of those things that we can sort of hang on and say, oh, okay, if we can understand more about different cultures, this will solve the problem. But it is still true that once, when you're in that zone, you're also in the zone of potentially reinforcing stereotypes and using shortcuts as well for decision making. So proceeding with caution. And as well, I think it's easy then within a cultural competence training initiative to not look at some of the things that are very uncomfortable to look at, such as institutional racism, white privilege, and class differences that could continue to account for some of these issues, even if we are all well educated about one another's cultures. There's also some really nice evidence that providing healthcare providers with communication training and making it more patient-centered improves adherence. So there was one meta-analysis that came out in 2010 where they looked at a number of studies to improve physician communication, and they have some really nice findings. Basically, there was one study where there was sort of zero effect. Every other study had a positive effect, and the overall effect was solid as well. But they found that the risk of non-adherence was much greater. It was greater in patients of untrained physicians, and also if a physician had been trained in communication skills, the odds of a patient adhering were increased. So there is some evidence that this can make a difference as well. In terms of medication beliefs, as I've mentioned earlier, there is evidence that these beliefs vary among individuals, within families, and across cultures. And it is true that, these are associated with medication adherence across many conditions as well. But it's really important to make sure that if we're addressing medication beliefs, these occur in the context of open patient-provider communication, and also, as I mentioned earlier, include a discussion of complementary and alternative medications as well. So just wrapping up, it's true, and a big issue, of course, that disparities in medication use are widespread and across diseases, consistently found. There is evidence and patterns of communication in healthcare between healthcare providers and folks who are different from them culturally as well, and that this may impede adherence. It's really important to be aware of the cultural and historical antecedents to medication beliefs and barriers as well. And I think not knowing that is can cause some significant issues and missteps. But there are some things I think that we can do, emphasizing collecting more data and making sure our data are solid so that we understand what's happening locally and we make ourselves accountable to spark change in those areas. That we consider different kinds of training for healthcare providers as well. And also addressing medication beliefs using a shared decision-making model, I think, is something that holds some promise. I haven't talked about some of the big things like huge structural changes that are happening in healthcare that could also make an impact. Again, that's perhaps a different talk, but all of these are happening again within a very shifting healthcare environment where there are different pressures on healthcare providers. So I think we're also in a situation potentially of positive change, but there are also some risks ahead as well. So, thank you.